WPSU is your source for Penn State sports, Penn State research, Penn State community. But we can't do it without your support. Make a contribution today and get a DVD of your favorite Penn State show.
Presentation of To the Best of My Knowledge on WPSU is made possible in part by support from the Penn State Alumni Association, informing, involving, and inspiring Penn State alumni and students through its publications, programs, and events. On the web at alumni.psu.edu. And from the members of WPSU.
From the studios of Penn State Public Broadcasting, this is To the Best of My Knowledge. I'm Spanier. Tonight we'll talk about modern childbirth. Childbirth can be a tense yet joyous event for expecting parents who are eagerly awaiting the arrival of their newborn baby. Most people agree that childbirth today is managed much better than it was 1 or 2 generations ago. In fact, most women can expect a healthy journey through pregnancy and birth. Tonight we'll discuss the management of modern childbirth. We'll also take your phone calls at 1-800-543-8242. And you can also email us, email your questions to response@psu.edu. And now let's meet our guests. Dr. John Repke is a university professor and chairman of the Department of Obstetrics and Gynecology in Penn State's College of Medicine and obstetrician gynecologist-in-chief at Penn State's Hershey Medical Center. Also joining us is Penn State's College of Medicine Dr. Jamie Pauli. She's assistant professor of obstetrics and gynecology and a physician at Penn State Hershey's Medical Center. I want to thank you both for being on our program tonight. This is a fascinating topic to so many people, and most families obviously have a very direct connection with the whole topic of childbirth. But as we mentioned, there have been changes over the years, and it's a field like any field of science or medicine that continues to evolve. And I think one of the things, let's ask you this, Dr. Repke, that people wonder about is this decision that many families have to make about whether to have a baby in the hospital, which I think is what most people do, but also in a birthing center or at home or in a different kind of setting. Could you just review a little bit the pros and cons of having your baby in a different location?
Sure. It's a great question, and it's certainly one that has its own level of controversy associated with it. If we think generically about the development of our healthcare system and hospitals, most of it is designed to try to minimize risk and maximize outcomes. If we think about childbirth as not a disease like most of medicine deals with, but the end of a physiologic process, it makes perfect sense for people to think, why do we need to be in a hospital? Why do we need to be in such a technologically intense environment? Why can't we be in a birth center? Why can't we be in our homes? And it really is about acceptance of risk. And just to put this in very basic context, if we go back to the 1930s, the maternal mortality rate, so the number of women that might expect to die in childbirth, was around 500 to 700 per 100,000 births. In the United States today, largely because of having deliveries in hospitals or in healthcare facilities capable of dealing with emergencies, that's gone from about 500 to 700 per 100,000 to about 7 to 8 per 100,000. So for that additional 692 deaths that might occur, sure, the overwhelming number of the 4 million births every year that occur in America are going to end splendidly. But there are so many things that can be prevented. I think that's why there's been this gravitational move toward healthcare facilities to try to minimize risk.
Dr. Paulai, could you point to one or two of the more interesting modern advances in childbirth?
Well, I think part of it is just more the individualization of each woman's experience in childbirth. I think that, and again, I can't necessarily speak to all of the past, but for now we have an educated, very internet savvy, very, opinionated group of women who would like their childbirth to go one way or have an interest in going, one direction versus another direction. So I think probably for modern childbirth more than anything else, it's that the woman herself has a real interest and a real, drive towards having her baby a certain way, and being educated and having all of her options kind of given to her there.
Now, with my children, I went to a Lamaze type childbirth class. Is that still in vogue? Is being done quite a bit? And do you recommend it?
I think that there are a lot of different options actually in terms of educating parents, not just the mother, but also the father of the baby and even the siblings of the expecting baby, in terms of how that family unit can accept that, that birthing process. There are a variety of different ways. There are breathing techniques. There are labor coaches. There are, classes that are run by nurses who explain what actually happens on labor and delivery. Why you'll get an IV, what an epidural is, what are the risks and benefits of those sorts of things. So I think there's a big range of all different types of things that include things like Lamaze still. Yeah. Absolutely.
Just out of curiosity, how many babies a year are born at the Penn State Hershey Medical Center?
Between 1,700 and 1,800 births per year.
So that would be
about five
or six a day.
Yeah.
Yeah. You don't do them all between you two, do you?
No. we have a little bit of help.
How many different people are involved?
Well, in terms of our delivery service, we have 4 members of the Division of Maternal and Fetal Medicine, in addition to Dr. Paulai, who would make our 5th. And then in our Women's Health Division, we currently have 6 physicians with 2 more about to join us. So we've got about a dozen physicians that are involved in assisting with deliveries, and that's attending level physicians. In addition, we have a residency training program that has 5 residents per year for a 4-year training period. So that's 20 additional medical school graduates that are assisting the attending staff in managing and taking care of these women.
Now, I have at least 100 questions I want to ask you, but the phones are already ringing off the hook, and I see that we have a number of people in the queue. So let's take a couple of questions, and then I'll come back with some of mine. Let's start with Diane, who's calling from State College. Hi, Diane. You're on the air.
Hi there. I recently had a baby, and I am aware that many women today are interested in natural childbirth. I'm wondering if you can shed maybe some light onto why here in State College we don't have the opportunity of having midwives, and maybe what can we do to get them back here in town?
Well, State College is not New York, so it's a smaller community, and how frequently do you find that there are midwives doing deliveries or working with hospitals like yours? I'm not sure if either of you are right in touch with the State College situation. Maybe you are.
Well, it's, I'll try to address that, and Dr. Paulai can certainly chime in as well. In previous institutions that I've been involved with, we have had very active midwifery services. It seems to be very regionally dependent. It depends on, frankly, consumer demand. There are many people that feel that they want to see a physician for their childbirth. They don't want to see a midwife. And if there's not a demand there, a midwife needs to have a critical number of patients that they can follow in order to make economic sense for them to practice, because they have expenses, they have malpractice insurance, etc. So I would say that it's probably not a phenomenon unique to State College per se, but maybe in fact a phenomenon unique to the area and what consumers are demanding. If more and more women are like yourself and looking for that option, I guarantee you that option will find a way to make itself available. And
how, as an obstetrician gynecologist, do you feel about midwifery? That would be a question some people might wonder.
Well, I've worked with many midwives in the past during my residency training program. We actually have midwives and nurse practitioners who are part of our obstetrical service at Penn State. They don't deliver the babies, but they're part of our outpatient clinics. They actually care for more of the OB patients probably than even the physician providers do in some of our sites. And we have a very close and really supportive relationship with our midwives and nurse practitioners. So I think that their expertise is valuable. I've always enjoyed working alongside with them, both as a resident and as an attending. And I think it would be great if they were part of a delivery population as well. So
great, thank you. Next, we've got Jen calling from Bellefonte. Hi, Jen.
Hello. I was wondering, what is the difference in recovery time between natural birth and a C-section now?
Dr. Paula, why don't you go ahead?
Sure, absolutely. Well, I think that for a vaginal delivery or a natural birth, as you said, the recovery time for the vast majority of our patients, they go home from the hospital 1 or 2 days after the baby's born. Obviously, you don't go home from the hospital 100% feeling like yourself after you've had a baby. But for the most people, they're up and caring for a newborn immediately, so you kind of have to recover quite quickly. I think the difference is that with a C-section is that it is a major abdominal surgery, so you have an incision. You have more pain that's related to the incision as opposed to the pain that you may have from a vaginal delivery. So I think that, like any other surgery, you have more pain. You might require more pain medicine for a little bit longer period of time. But again, for the vast majority of our patients, they are now caring for a newborn, and they recover about as quickly as they need to in order to, take care of that baby that's getting up every 2 to 3 hours.
And for a cesarean delivery, does that typically add 1 day or 2 days to the hospitalization?
Usually 1 day, sometimes 2, depending on the patient. Yeah, absolutely. And depending on if they've had a prior cesarean before, some women choose to go home a little bit earlier if they've had one before, and this is their second or third. It really is very patient dependent, though.
One of the big topics in the popular literature is about C-sections generally. There's been speculation over the years that you're seeing more of them because of malpractice. You're seeing more of them because of the convenience of the physicians or even the convenience of the mothers. But give us the scoop on that. Is there indeed an increasing proportion in recent years, and how do you put it all in perspective for us?
That's a great question, and I think if I had the answer, I'd patent it and sell it. But I think if we look at it as a continuum, there are a lot of factors that have gone into the increasing cesarean section rate. In 1970, so not that long ago, 40 years ago in the United States, the cesarean section rate was 5%. In 1980, the cesarean section rate in the United States was about 12%. By 1985, it was about 15%. By 1990, it was about 18%. With the rising rate of cesarean section, the United States Department of Health embarked on something called Healthy People 2010, which was supposed to be designed to get the cesarean section rate down by 2010, this year, to 15%. The cesarean section rate in 2009, which is the last year we have data for, is almost 33%. Now, why is this? Well, some of it is fear of litigation. Some of it is patient expectations, not wanting to take any risks if these risks are going to be transferred to the baby, and rather take the risks on themselves, meaning mom being willing to undergo major surgery if there's any perception that this might improve the likelihood of a successful birth for her child without any other difficulties. The population's delaying childbirth, so women are having their first child at older ages. There's an increasing use of assisted reproductive technologies, which in the 1990s resulted in a peak incidence of higher order multiple gestations like triplets and above. Now that's come under more control, but we have a much higher rate of twin gestations, many of which deliver by cesarean section. So there's a whole host of reasons that account for this increase. And by the way, it's not unique to the United States. We're seeing this around the developing world. The cesarean section rate is increasing for a number of reasons, not all of which can be explained just by medical science.
Let's take a call from Andrea, who's calling from Bellefonte. Hi, Andrea.
Hi. I was wondering how maternal mortality rates in developing countries compare to the rates in the United States you had just been discussing and were discussing earlier. And also, what are the most common reasons for death during childbirth?
Well, that's a great question, and it really shines a light on a very, very important topic. And, you know, with all of the debate about health care in the United States and our health care system, we really, I think, need to take a step back and look at how fortunate we are. And I'm going to put this in terms of a pretty graphic description of what maternal mortality is like worldwide. In the United States, as I mentioned, we're talking about a maternal mortality of about 8 per 100,000. Worldwide, in developing countries primarily, maternal mortality would be the equivalent of a 747 jumbo jet full of pregnant women crashing without survivors every 4 hours, every day, 365 days a year. It's an incredible problem worldwide. And the major causes of death are infection, complications relating to blood pressure, and hemorrhage or blood loss. And these are things that developing countries have been able to manage very, very effectively with antihypertensive medications, the ability to deliver women at earlier stages of pregnancy where their child can survive, our ability to utilize blood products, availability of effective antibiotics, intensive care. So it really is a huge problem worldwide. It's something that has not gotten the attention it's deserved, but I think it really should force us to take a step back and say, you know, with all of the other problems we can identify with health care, we've done a pretty darn good job with delivering care to moms.
I'm sure that a lot of the improvements and the overall situation in the United States is due to care for women when they're pregnant, the fact that they're being closely monitored when they're in the hospital, and the equipment that we have available to keep an eye on them, which brings up the topic of fetal heart rate monitoring, something that, you know, in the modern era, I think is very common, and we didn't see much of it before. Ultrasound. Could you talk a little bit about what those things are and how dependent you are in your practice in using those kinds of methodologies?
Okay, well, you bring up fetal monitoring or fetal heart rate monitoring, which is something that every prenatal visit we do auscultate or listen to the fetus's heart rate using a Doppler machine as a general rule. After a certain gestational age, you can hear it externally. So we do monitor at each prenatal visit, and that's sort of a standard thing that we do. While on labor and delivery, when a patient is either being evaluated for either a medical issue or while she's in labor, we also do continuous fetal monitoring where we're looking at a fetal heart rate tracing. We look at a number of different things that help us know what the intrauterine environment is, how the baby's responding, whether it's to labor or for whatever else is going on with the mom at that time. I think we are reasonably dependent on that in terms of, you know, especially when you're running multiple people are in labor. It helps when you can look at a fetal monitor strip and know, okay, that baby appears to be doing well, appears to be tolerating labor very well. It has never technically been shown to alter outcomes, but we do depend on it on our labor and delivery. It also helps us when patients are being induced and or they have a medical issue that we need to be watching, so we know that the mom and the baby are doing well. In terms of ultrasound, we use ultrasound for a variety of things. We use it to diagnose pregnancy in general. We use it to diagnose multiple gestations, so that, you know, so that's one of the ways that we know earlier that we have more than one fetus in utero. We also use it to monitor fetal growth and to look at the fetal anatomy and to look at, you know, the fetal heart and the brain structures and the extremities and things like that.
Do you have patients very often who just say, I don't want any of that stuff, I've heard it's a little too artificial for me?
Well, this is an interesting question from a generational perspective, because in my training days and early days on faculty, The 1970s and 80s was much more of that type of response, and today it's much more about when do I get my ultrasound, when can I have my next ultrasound, can I get some of those 3D pictures to take home with me, and of course you're going to listen to my baby's heart rate during labor, otherwise how are you going to know that it's okay? So today I think my perception, and it may be wrong, but this one individual's perception is that the younger generation of women in their 20s today that are having children are much less technologically averse than the 20-year-olds of the 1970s.
Right, right. Let's take a call from Susan, who is calling us from Lamont. Good evening, Susan.
Good evening. I was glad to hear Dr. Repke say that childbirth is a very natural physical experience. Not all women are candidates for a midwife, but for instance in Germany, having a baby delivered by a doctor is very unusual. Babies are delivered by midwives who spend a lot of time with mother from the beginning of the pregnancy until 2 or 3 weeks after the baby is born, so that the mother gets home visits. She knows exactly what to expect, and it's not the best thing for everybody, but for a healthy woman who has no complications, it's a much more comfortable situation for the mother and for the baby. I mean, and for the whole family. It's just an amazing thing to see. I went to be the caregiver when our grandchildren were born, and the midwife was there every day helping with all kinds of things, both before and after the baby came. And it's not as expensive. People trust their midwives. They're not being sued. It's just a much more effective system. And the clinics, the birthing clinics, are in the hospitals. So if there's a problem, there's a physician right there, and it's an amazing thing that works.
Well, thank you for that perspective. Let's turn to a couple of other topics. Episiotomies. Maybe you could explain what an episiotomy is, and then let's talk about whether that is still standard today or whether there's a diversity of thinking about their use.
Okay. Well, the basics of an episiotomy are that it is a surgical incision made in the vagina to facilitate delivery, whether that be to make some more room for the baby or whether that be to allow for the baby to be born a little bit more quickly due to a variety of reasons. I think that maybe before my time, episiotomies were more of a standard. Now, and what my training was, is that we do not routinely use the episiotomy for deliveries. There have been very good studies that have been done that have shown that the type of tear or laceration that a woman has after a vaginal delivery is no worse if you allow her to do that naturally versus cutting an episiotomy. So as a general rule, we don't use them for all patients. There are obviously always going to be there's always going to be a specific situation where an episiotomy may be useful, and it is a surgical technique that we are taught in residency, but it is not the standard of care anymore.
And Dr. Repke, wouldn't this be a good example of something that has definitely changed in the practice of childbirth? The episiotomies were very routine because there was a fear of a third-degree tear, a tear that would go from the vagina to the anus, and that was presumably difficult to repair, and therefore episiotomies were standard, but not so much now.
Yes, exactly.
Can you talk about how the thinking evolved on that over time?
Yeah, and in fact, I appreciate the opportunity to toot my own horn a little bit. I authored the practice bulletin published by the American College of Obstetricians and Gynecologists on episiotomy, and you're exactly right, Dr. Spanier. 30 years ago, probably 80% to 90% of women having a vaginal delivery in the United States had an episiotomy performed. The recommendation now is that probably a rate of 30% or higher is not just viable. And in our institution at the Milton S. Hershey Medical Center, our episiotomy rate, and we actually just reviewed these data because we have to present them to our quality assurance group tomorrow, is less than 5%. Now, interestingly, the thinking has changed insofar as yes, the greatest risk factor for that extension seems to be the episiotomy rather than lack of one. But now what people are debating, and we'll see if in another 20 years the thinking may change again, is does the lack of use of episiotomy potentially predispose women later on in life, 20, 25, 30 years after childbearing, to a higher rate of urinary incontinence or other dysfunction of the pelvic floor musculature because their second stage of labor may be prolonged? This is a debate. I'm not trying to convince anybody that this is or isn't the case, but this is an active area of investigation, and I suspect in 15, 20, 25 years we're going to be hearing more about this, and maybe it will affirm that we've made the right decision to move away from episiotomy, or maybe we'll find out the pendulum has swung a little too far and somewhere more toward the middle is where we ought to be.
If you're just joining us, I'm Graham Spanier, president of Penn State, and this is To the Best of My Knowledge on WPSU, Penn State Public Broadcasting. Our topic tonight is modern childbirth with our guest, Dr. John Repke, university professor and chairman of the Department of Obstetrics and Gynecology in Penn State's College of Medicine and obstetrician gynecologist in chief at Penn State Hershey Medical Center, and Dr. Jamie Pauli, assistant professor of obstetrics and gynecology and physician at Penn State's Hershey College of Medicine and Medical Center. You can join the conversation by calling us at 1-800-543-8242 or email us at response@psu.edu. Well, we talked a little bit about C-sections, and maybe further on that continuum is the subject of the use of forceps or suction for a vaginal delivery to help get a baby out quickly or because of the positioning. Can you give us an update on what the decision-making is around the use of different tools for a vaginal delivery and when you make a decision one way or another as to how to go about it?
Well, I think that the very first thing that you need to decide whether or not someone can have a vaginal delivery or not is how their labor is going or how their labor is progressing. So we have certain criteria that we follow that tell us, is a woman's labor following an average curve? Does she appear to be following the stages of labor? Even with augmentation, with medication that we use, do things seem to be going in a reasonable manner, in a reasonably timely fashion that's for the safety of both her and for her baby. When it comes to the decision about whether to do an operative vaginal delivery, we have a number of criteria that we go through. So you need, the experience of the physician, the being absolutely or being very sure, absolutely sure of the positioning of the baby's head. That really tells you whether or not you can perform a forceps delivery or a vacuum delivery. The willingness of the patient to undergo an operative delivery. They need to be, it's informed consent like anything else that we do in medicine or obstetrics. The patient needs to be a willing participant in this type of procedure. It is a procedure. It is always the patient. If the patient chooses not to have an operative delivery after the risks and the benefits have been explained to her, then she may choose to have a C-section if she does not, want the baby to come out in that manner. And then really in terms of choosing whether or not to use a vacuum, or the suction as you referred to it, or the forceps, really as a general rule seems to be provider dependent. Their comfort with that tool, the patient's anesthesia comfort, and whether or not that you feel reasonably sure that it would be a successful attempt.
Dr. Repke, would you add anything to that analysis?
Well, I think Dr. Pauli summarized it very nicely, and it gets back to something we talked about a little bit earlier, which is, again, this willingness to accept risk. And so I think if we were to look at utilization of operative vaginal delivery over the past 25 years, there's clearly been a decrease, largely because of, I think, patients not being willing to take any risk with their child if the mother can reduce that risk by acquiescing to a C-section, to put it that way. And there's also fear of litigation, because certainly if you have an operative vaginal delivery and a child is born with any type of disorder, whether it be immediate birth trauma, whether it be subsequent developmental delay, the experience has been that not infrequently this gets traced back to events of the actual childbirth, whether that's justified or not, and that's led to a reluctance of physicians to use that technique. I can tell you as an examiner for the American Board of Obstetrics and Gynecology, forceps are falling into more and more disuse in favor of vacuum extraction. Whether that's a good thing or a bad thing, I think the jury's out. But certainly the same types of harm can be inflicted with a vacuum as with forceps. So again, just to reiterate what Dr. Pauli said, I think the important thing is make sure that you understand the woman's anatomy, the anatomy of her pelvis, where the baby's head is, that it's low enough that you're almost certain that this can be effectively accomplished with relative ease. And if those criteria can't be met, then a cesarean section in this day and age is probably the preferred approach.
And for those who may not be familiar, describe what the vacuum extraction involves.
So a forceps delivery is basically what people have termed two large salad spoons that get placed into the vagina around the baby's head, and then you can gently, with the assistance of mom pushing, help to pull the baby through the pelvic outlet and effect delivery. A vacuum extractor is essentially a suction cup, and what you're doing is you're placing a small suction cup on the baby's head, allowing for suction to develop until you get a good seal around the cup, and then you're using that as a traction instrument. The thinking is that you can't apply as much traction with a vacuum as with forceps, and so you're more likely to have that suction cup pop off than end up using injudicious force and then end up with a birth injury. But the fact is, these are very, very technically complex operations, vacuum or forceps, and have to be done by an experienced clinician who has done these multiple times in the past successfully.
Yes, thank you. Kathy from Julian is on the line. Thanks for calling into our program tonight.
Thank you. I was wondering if you could give us an idea of what the difference in cost is between a vaginal delivery and a C-section.
That's a great question.
Yeah, you probably neither of you do the billing.
Everybody's looking at me.
I do not know.
I'll try to give it to you in some generic terms, because I think, again, as we get deeper and deeper into a healthcare conversation in the United States, it's important for people to recognize that in general, there are two main costs that go into, and let's just say, an uncomplicated delivery. There's certainly the provider cost or the professional fee, but that represents probably about 20 to 25% of the total cost. The remaining cost is the hospital cost, the cost of being on labor and delivery, which is essentially like an intensive care unit, the cost of being in a hospital bed for be it 1 or 2 days, or if you have a cesarean section, use of the operating room, and so on and so forth. These costs can vary by region of the country, but I would say on average for a normal vaginal delivery, when all is said and done, and let's just assume it's uncomplicated labor, vaginal delivery, 2-day hospital stay, and you utilized epidural anesthesia, so you had an anesthesia bill as well, that's probably going to be somewhere in the $5,000 to $7,000 range. And then obviously if you have a complicated delivery, it's going to be up from there. And then there are potentially costs that will go along with the newborn. If you have a child that has requirements for neonatal intensive care, in extreme cases, these can be bills that get into the hundreds of thousands, if not millions of dollars. So clearly these are not inconsequential costs. But an average delivery vaginal is probably going to be in the $5,000 range. A C-section maybe in the $7,000 to $10,000 range.
Now, going back to that earlier generation that you referenced before in the 70s and 80s, a lot of women wanted no medication at all. That was, in a sense, the standard, and then, of course, some people did and others needed it. And now the thinking on that has evolved as well. You've made a couple of references to epidurals. Dr. Pauli, could you describe perhaps for us some of the range of options for medication that are available, and what might go into a decision about where on that continuum to be?
I think we're getting back to that part where it's all about what the woman's individual needs or wants are for her labor. But obviously, and in any hospital, but in ours as well, the option of a quote-unquote natural childbirth is still there. A woman does not have to have medication for pain management during her labor. She can utilize breathing techniques, she can utilize massage, she can utilize our medicine balls that they bounce on, or rocking chairs, moving around their rooms. All of that is still an option, again, in the otherwise uncomplicated patient who does not have other medical issues that would maybe necessitate other issues.
What percentage of your patients just want the completely natural approach?
I don't know if I've never actually looked at the exact number, but I would say maybe in the 20% range, maybe a little less than that.
And when all's said and done, that percent that want to begin that way don't necessarily end that way.
Right. But it is clearly the minority of patients now who end up in that range.
Absolutely.
And so what do you find more commonly actually happens?
Well, I would say that probably the most common thing is that women have regional anesthesia or have an epidural. But before that, if they're interested in, before they get to an epidural, if they're interested in having their pain managed a little bit differently, we do have IV medication, which is essentially an IV narcotic. There are a variety of different ones that can be used. They can be used almost throughout labor for throughout an entire labor if a woman wishes to have it that way. Many women choose that in the beginning of their labor, and as their labor progresses, then tend to ask for an epidural for their anesthesia. The epidural provides them, for the vast majority of women, the ability to still move their legs. They can't necessarily walk around, but they do not feel the contractions that they're having, so they're able to rest through their labor, and they are not in as much pain or any pain at all.
How about for a C-section?
For a C-section, if it's a scheduled C-section and it's not something that's done in labor, we actually can use spinal anesthesia, which is a little bit shorter acting, has a little bit different coverage. It doesn't necessarily, you can't usually move your legs as much with a spinal, a little bit of a more denser coverage of pain. We can also use epidurals for C-sections as well. Epidurals that have been used in labor can be rebolused or given more medication by the anesthesiologist so that a C-section can be done with reasonable comfort or complete comfort for that woman. A very rare patient may require, for again, a number of medical issues, whether it be previous spinal surgery or not being able to have an epidural or regional anesthesia for a number of medical conditions, may require general anesthesia. So that would be a breathing tube and general anesthetic administered by an anesthesiologist as well.
So Dr. Repke, under what circumstances would you go beyond an epidural for general anesthesia or something that would be beyond the typical management of a vaginal childbirth?
So I think for an anticipated normal spontaneous vaginal delivery in a woman who wants anesthesia, epidural is probably the preferred method. And if I could, I just want to make a comment, because there are a lot of opinions out there about epidural anesthesia, and the data, the scientific evidence that we have, despite the fact that there are opinions to the contrary, would suggest that epidurals do not seem to impair the progress of labor or lead to cesarean section. Now, the critics of the statement I just made will say if you look at epidural utilization and you look at cesarean section incidence, they're both going up at about the same rate. But when this has been studied fairly rigorously, it's really not been possible, at least to date, to demonstrate that epidurals contribute to an increased rate of cesarean section. The most common reason to go from whether it be epidural or spinal anesthesia to general anesthesia will be inadequate regional anesthesia. So you don't get an adequate block to either provide the level of pain relief that you need or there's some other supervening issue that requires that the patient go to sleep under general anesthesia. Now, we would virtually never, and it's always dangerous in medicine to say the words always or never, but we virtually never utilize general anesthesia for a vaginal delivery. So most commonly where we would use it is the patient who has an epidural, who has a spinal, We go into the operating room. Before we begin the surgery, we do what's called a test. And with that test, the patient clearly feels a pinch or feels what we're doing. We know that patient doesn't have adequate surgical anesthesia. Now they have to go to sleep.
800-543-8242 is our telephone number if you'd like to join this conversation as we're talking about modern childbirth on To the Best of My Knowledge. I'm Graham Spanier, president of Penn State, and do feel free to give us a call and join the discussion tonight. I wasn't sure if we were going to have any men who would call into the program with questions, but I knew I could count on Walter from Warren, and he is on the line with us now. Good evening, Walter.
Mr. President Spanier, thank you again for taking my call. And I have two questions. One is for Dr. Repke. When he was describing the litany of associates that he has in his stable doing delivery, I was impressed. It sounds like he has a full staff. On the other hand, does the Commonwealth of Pennsylvania also have a full stable of obstetricians in their stable? I mean, are there enough obstetricians in Pennsylvania? And the other question I wanted to ask...
Hang on to your second question, because let's tackle that one first. We were talking about that a little bit before we went on the air. How are we situated in Pennsylvania with obstetricians, gynecologists?
Well, I think it's a concern. I think that it's more of a concern in the eastern part of the state, specifically in the Philadelphia area, and from what my colleagues tell me that hold my position in the medical schools in that city, costs of practicing obstetrics, specifically as it relates to malpractice, have been a major driver of people to either early retirement or to give up the obstetrical part of their practice in favor of gynecology. As you may be aware, Walter, in the eastern part of the state, many smaller obstetrical units have closed down, and the number of hospitals offering obstetric services has shrunk, creating a tremendous burden for some of those health centers, especially those that are providing for either the uninsured, underinsured, or Medicaid population. So I think it is a bit more of a crisis in the eastern part of the state. We're a little bit sheltered from that in central Pennsylvania. I don't think that there is a shortage of obstetricians in central Pennsylvania. I don't think there's a shortage of obstetricians in the urban parts of western Pennsylvania, but people do forget that there are large swatches of rural Pennsylvania that have inadequate numbers of healthcare providers in all disciplines, and this is not a problem peculiar to Pennsylvania. This is in many parts of the central U.S. where rural populations require healthcare, but the population density may not be sufficient to support having specialists, and that's why I think as a university we remain so committed to trying to train physicians in primary care that potentially are going to remain in rural areas to provide health care for those populations, including obstetrics. So sorry to be so long-winded, but it's a great question, and it's a pretty complex one.
Well, let's see how good his second question is. Walter, you had another question.
Yeah, it has to do with the ultrasound. There's a great concern in the country about controlling medical care costs, and rightfully so. Now, in the course of a normal pregnancy, many women routinely get an ultrasound early on in the pregnancy. They get an anatomic survey later on, and sometimes they get another ultrasound to check growth. How much bang do you get for your buck with 2 or 3 or 4 ultrasound examinations during the course of a normal routine pregnancy? And we're not talking about the complex ones or one where there's a suspicion of something going wrong, but just the straightforward, normal pregnancy.
Dr. Pauley?
Sure, that's a really great question. I think that it's a valid one because I think that even in a normal, regular pregnancy, there is value to ultrasound. We use ultrasound in the first trimester to diagnose the pregnancy, to make sure that the pregnancy is progressing in the way that it should be. But I would say probably the #1 reason why we use it is to confirm the due date or the gestational age of that pregnancy, which does alter the management of that pregnancy maybe throughout. In addition, we do use first trimester ultrasound in some of our genetic screening programs. So a lot of women find a use to that early ultrasound, not only to confirm their due date, but also to utilize some of the genetic screening tools that we have. Beyond that, I think that the anatomical survey or the anatomical scan that we do somewhere around the 5-month range or the 20-week range has a lot of value in terms of making sure, again, that the pregnancy is progressing on its own, progressing well, and that there are no issues with either the fetus or the mother or the placenta that might need to be addressed later in the pregnancy. Beyond that, I don't know that in an otherwise normal, healthy pregnancy where the mother is following appropriate weight gain, she's feeling well, her blood pressures are controlled, and she doesn't have any other medical issues, there may be no use for another ultrasound later in the pregnancy. That being said, there are specific reasons, specific indications to be looking at a baby's growth later in pregnancy, whether it be a set of twins. You want to make sure that those babies are growing appropriately because they are at risk for issues. Even in an uncomplicated twin pregnancy, we would still check to make sure that both fetuses are growing appropriately.
When people go to the doctor for any number of things, sometimes you have the office visit, but then if you need an x-ray, it's a separate charge. If you need a blood test, it's a separate charge. Is an ultrasound a separate charge in the course of the management of pregnancy? Is just something you routinely do, which is a part of the office visit, or will it show up as a separate thing on the billing?
I'm pretty sure that it's a separate charge.
Yeah, it will depend on the level of ultrasound that's being done. So if the obstetrician is using the ultrasound transducer as an extension of their stethoscope, so they're doing a very limited scan to just see fetal heart motion, generally, we would not submit a separate charge for that, nor would one probably be honored if we did. But if you are doing a detailed ultrasound in any trimester and adhering to American Institute of Ultrasound in Medicine standards for what that study has to comprise, that would be a separate charge. Now, many insurers will include an ultrasound as part of the global fee for prenatal, intrapartum, and postnatal care, and ultrasounds above and beyond that would be the responsibility of the patient, or in some instances the responsibility of the healthcare institution that's providing that service and someone that is not going to be able to pay for it.
But what you've said illustrates the relevance of Walter's question. Indeed, there's an extra charge. It's paying for the equipment and the time of the people administering it. So it has contributed to upping the costs, even while it's contributing valuable information that makes you do your job better.
Yes. Well, you know, and interestingly, one of the things that does go on in the non-medical realm is that patients have access to commercial ultrasound vendors that will provide them with entertainment photos of their fetus, and these are out-of-pocket expenses that people will pay. And there's been a great debate in the ultrasound and medical community about the appropriateness of using medical technology for entertainment purposes, to the point where I don't know if other states have done it, but I know that the state of Connecticut has passed legislation making that illegal, that that is no longer allowable, that medical technology must be utilized for medical purposes, cannot be used for entertainment purposes. So it gets back to costs and what we use our equipment for, and who's picking up the tab for that.
I want to take a question that came in via email. I've heard some horror stories about epidurals gone wrong, where the wrong part of the body is affected. How often does that happen?
I am not aware of that happening with epidurals. Now, if I can read into your question a little bit, occasionally what can happen is that an epidural, by virtue of how it's done, is an injection of a fairly large volume of anesthetic agent into the epidural space. So without making this too much of an anatomy lesson, in a spinal anesthetic, it's a very, very small volume that goes into the spinal fluid. Rarely, the epidural needle can get into that spinal fluid space and somebody can get what's called a high block, where they would have essentially be paralyzed and unable to breathe. And in a hospital setting with anesthesiologists present, while that's certainly not something anybody would wish on themselves or a relative, let alone a spouse, it's manageable. It generally doesn't result in any complications. But that would be how I would interpret your question of epidurals going wrong, would be you get a high block, it requires respirator support until that block wears off. Beyond that, at least in my 32-year career, I'm not aware of any cases of paralysis, residual neurologic dysfunction, anything else related to epidurals. I'm sure it's happened somewhere, but I've never seen it.
Just talking about your profession for a moment, the words obstetrician and gynecologist are almost always tied together as one set of training and one continuum of practice. But Dr. Repke, you mentioned earlier something about some people wanting to move away from the obstetrics part and focus on the gynecology part. How common is it now for there to be a degree of separation in these professions and people choosing to go one direction or another? Maybe Dr. Paula, you could talk about your own training and whether there were some people, I mean, you're still relatively young, but people who coming out of medical school and in their residencies deciding already to make that kind of split, or are they really linked for many years to come?
Well, I think that one of the things that appeals to most of us who go into obstetrics and gynecology is that there is a huge variety of things that we're able to do. We have one very specific patient population, women and their health care, but we can do all sorts of things from, you know, delivering their babies to performing hysterectomies to caring for sexually transmitted diseases to doing contraceptive counseling. And so for all obstetrician gynecologists, we do a 4-year residency program that teaches you and trains you in the entire realm of our subspecialty. Now, within that subspecialty, there are even more subspecialized groups. So there are some groups, such as Dr. Epke and myself, who go into maternal fetal medicine, which is obstetrics only and high-risk pregnancies specifically. There are also groups that look at who work in infertility, so gynecology, but also on the edge of obstetrics as well, because they're helping women who have issues conceive babies and have successful pregnancies. In addition to that, there are gynecological specialties such as oncology or the cancers of the women's healthcare system. There's also gynecologists who just choose to do surgery. And so I think that I think it's probably becoming more and more frequent that people are thinking about subspecialties, whether or not that, you know, the vast majority of obstetrician gynecologists are still going to be general OBGYNs, and they won't perform all of those, at least for a certain portion of their career. But there are options if you're interested in becoming even more specialized.
Right. This is not a trick question, but it's a little tricky, I think, and I'll put you on the spot a little about age. Women are having fewer children, and those they're having later. What is the prevailing thought about how old is too old to have a child? At what age would a woman come into you and say, I'm pregnant, and you say, well, here are the issues that we have with your high-risk pregnancy given your age? Can you just talk about how old a woman can be these days and have a baby, and what the issues are when they get into that zone? Dr. Repke?
Well, that's a tough question because there's chronologic age and, if you will, there's gynecologic age or physiologic age. I think when we deal with this particular issue in obstetrics and gynecology, it's most frequently couched in the conversation of assisted reproductive technologies. And lots of times there are arbitrary decisions made about what age is too old, and those decisions are largely unencumbered by data. The outliers seem obvious. The woman, I think, in Italy who had the child at age 70, most people would probably say that's too old, and I think she subsequently succumbed. And that would tend to establish that hypothesis of her being too old as maybe having been correct. On the other hand, women can naturally conceive in their late 40s. I think there's a lot that goes into what is the overall health of the woman. If assisted reproductive technologies are going to be used, there are techniques that can be used to try to establish the gynecologic age, things like looking, and I don't want this to get too technical, but the quality of the hormonal response to ovulation induction, the quality of the oocytes that are produced, the eggs that are produced. Lots of these things can go into that decision. So in the society that we live in, I think we have to be somewhat open-minded. We have to make sure patients are aware of what risks they're undertaking when they undergo assisted reproduction, when they become pregnant at advanced ages, and in terms of even their own resource utilization, what's the likelihood of a successful IVF cycle when you're 55 years old, and how much money of your own do you want to spend on this, knowing that your success rate might be abysmally low, depending on a whole host of other factors. So did I effectively hedge on that one?
Yeah, no, that's good. And so a woman in her 40s, do you have some patients that you see in that age range who are pregnant? And just because we only have a little time left, what 2 or 3 things are you especially looking for as you manage their pregnancy for them?
I think probably the #1 thing is whether or not that woman is interested in any sort of genetic screening, counseling, or diagnostic testing, because as a woman ages, her risk of having a baby with some sort of chromosomal problem or birth defects, etc., does go up. That doesn't mean that woman has to have that testing, but you need to know what is she interested in, how far does she want to go to know is her baby healthy. Yeah. And then I would say, you know, the overall general health of that woman and her risks for having complications of pregnancy, like hypertension, diabetes, risk of having issues in labor, and just, you know, close surveillance to make sure that she is healthy and has a good pregnancy.
We could pick almost any one of these subtopics and do another whole show. This is absolutely fabulous, and I want to thank you. Thanks to our guest tonight, Dr. John Repke, University Professor and Chairman of the Department of Obstetrics and Gynecology in Penn State's College of Medicine and Obstetrician Gynecologist in Chief at Penn State Hershey Medical Center, and Dr. Jamie Pauli, Assistant Professor of Obstetrics and Gynecology and Physician at Penn State Hershey Medical Center. And thank you for watching. Tonight's program will be stored in an electronic archive that can be accessed through WPSU.org. This site also links to online resources on tonight's topic. We hope you'll join us on Tuesday, March 23rd, when our topic will be comedy. To the Best of My Knowledge is a production of Penn State Public Broadcasting. Good night.
Presentation of To the Best of My Knowledge on WPSU is made possible in part by support from the Penn State Alumni Association, informing, involving, and inspiring Penn State alumni and students through its publications, programs, and events. On the web at alumni.psu.edu. And from the members of WPSU.
A copy of the program you've just seen can be purchased through Penn State Media Sales at mediasales.psu.edu or by calling 800-770-2111.